You're listening to Vet Synapse, a podcast connecting the world of research, innovation, and practical help to the veterinary profession. I'm your host, Dr. Philip Judge from Vet Education. Let's get connected with Vet Synapse. Well, welcome everybody to another episode of Vet Synapse. Now, we're here today to speak about a really important topic, the topic of perianaesthetic analgesia. Now, something we apply to our patients nearly every day in clinical practice, but the science and evidence base behind what we do is really important because it allows us to practice the best veterinary medicine for our patients whilst minimizing the risk of adverse events. And to help us guide through this topic, I'm going to welcome today Dr. Laurie Steiner from Zoetis Australia to the Vet Synapse podcast today. Welcome, Laurie.
Hi, Phil. Thanks for having me.
You're most welcome. Now, we've got some pretty exciting news on this topic, and that is that the Australian Veterinary Anaesthesia and Analgesia Advisory Panel has worked with Zoetis to produce an absolutely incredible resource on perianaesthetic analgesia. Tell us a bit about this project, how it came about, and what the goals of the guidelines are.
Yeah, absolutely. It was a bit of a passion project of mine, so very excited to talk about them. For the listeners, I am the technical lead of the anesthesia portfolio at Zoetis, and a large part of what I do is education. So that might be clinic trainings, it could be going to conferences and talking to clinicians there, as well as just answering questions from vets and vet nurses when they call Zoetis for advice. And as we know, anesthesia in particular is quite an undertaking, and it can be complex and quite daunting as well. So education helps us feel more comfortable and confident and therefore do a better job, as you mentioned as well. So what really became clear to me was that we as practitioners, we really do have the best intention when it comes to analgesia, and that's fantastic, but getting it right can be quite difficult. So analgesia is subjective, as we know, and it's variable. And when it comes to providing adequate pain relief in that perioperative setting, what I found was that there was still some grey areas on the how and the why. So whether that just be inexperience with some of the new techniques, maybe some conflicting recommendations from the literature. As we know, we do get a bit of conflicting sort of recommendations there, or simply just fear in changing protocols that have been used, for years in the same clinic. So that was quite apparent to me through doing those sort of educational events. And I actually recall a clinic in particular that reached out because they felt that they were relying really heavily on isoflurane, so more so than usual. What they'd found was that, all of a sudden their vaporizing seemed to be higher than what it used to be. And they had had all their equipment checked and everything was okay from that perspective. So they did call us looking for guidance. And when we assessed their anesthetic protocols, we actually realized that they had recently switched to using butorphanol in their pre-medications, because they'd felt, and rightly so, they felt that the animals seemed just better sedated at the point of induction. But the problem with this was that the analgesia that it provided was not sufficient for the surgeries that were being performed. So there was a bit of a mismatch there, and therefore those patients were requiring more isoflurane to actually maintain their anesthesia. So what we did, we switched this clinic back to methadone, and we played around a little bit with the dose that they were using, as well as the route of administration, because we know that that's really important as well. And that has a really great and positive result for that clinic. So it was experiences like this, similar, that really just sparked the idea of forming a panel of experts to produce a set of guidelines that would actually help clinicians navigate through appropriate use of various pharmaceutical products, different techniques related to analgesia in that perioperative setting. So we created the Australian Veterinary Anaesthesia and Analgesia Advisory Panel, and they consist of 6 members across Australia. We chose them not only because they are specialists in veterinary anaesthesia and analgesia, but also because they have substantial enthusiasm. You should have seen the room when we were, talking about this project. They had so much enthusiasm for it, and they have a lot of enthusiasm for continuing education as well. So the main goal was really just to create an easy-to-use, practical, evidence-based handbook that hopefully would promote best practice for anaesthesia and analgesia in that perioperative setting.
That's great. What a fantastic project. And I like the premise that it's accessible, because you alluded to, conflicting reports in the literature, and, everything that's published in the literature, goes through a peer review process, but our knowledge doesn't stay the same. So a recommendation that was made 7 or 8 years ago may be a little bit different from what a recommendation might have been, say, 3 years ago or 2 years ago. And our knowledge of pain, the use of pain scales and how we monitor patients as well is also quite different too. So, and that kind of brings me to the next point, because we know pain management is so important for our patients in terms of improving outcomes, reducing neurohormonal stress activation, stress and catabolism that can occur in patients with pain. But sometimes the assessment of pain in dogs and cats can be a bit of a challenge. So tell us a bit about the recommendations for pain assessment that are written about in the guidelines.
Yeah, absolutely. And I think what will come across very clearly to readers of the guidelines is this is a very important part of pain assessment. This whole, perioperative setting is just that pain assessment. So what the guidelines does is really acknowledge that pain is multifactorial, it's subjective, and it's really difficult to quantify. So in the veterinary world, as we all are aware, we don't really have, a gold standard for pain assessment. And we have that real lack of, I guess, the added challenge, I should say, of lack of verbal communication from our patients to tell us how they're feeling. So in the human world, we've got the gold standard of, the scale of 0 to 10. I'm sure we've all been asked that question of how much pain we're experiencing, 0 being nothing and 10 being, the worst pain we've ever experienced. But we can't obviously do that with our patients. So, if we do have a dog that's in post-op, recovery, how do we know that they are truly comfortable? And in recent years, we have made significant developments in this area around assessment of pain in veterinary patients. And subsequently, we have pain scoring tools that have been developed that are based on species-specific behavioural changes that our patients sort of express when they're experiencing pain. And the panel are really recommending the use of these pain scoring tools that have been created, but they do have a set of guidelines as to which ones we choose. So when we choose the pain scoring for, that's appropriate for our clinic, the recommendations are first that we're using a validated scale. So anyone who's listening who might not be aware of what a validated scale is, it's a pain scale that has undergone testing for effectiveness, reliability, responsiveness. Now, that one's a really important one. So a really good pain scale should be sensitive enough to actually show changes after treatment. So we're actually looking for an improvement in pain score. And then consistency as well between different pain assessors. Now, that I feel is really important as well, because it's not often that we have one clinician that's doing the pain scoring, throughout the whole day. We might have vets that start, or vet nurses that start and do a morning shift and then switch over to an afternoon shift or whatever it might be. So it's really important that results from pain assessment are repeatable between different staff members, not just, having to rely on one person doing it. And that gives us, I guess, peace of mind that it's reliable. Now, the difference with non-validated pain scales, they really lack that vigorous testing, and therefore the panel do not recommend using them. And that's really because they have very little to no research behind them. So that's one thing, making sure that we're using a validated pain score. The second thing is to ensure that we're using the right pain scale for the job. So, for example, if we're talking about the perioperative setting, we're really talking about acute pain. So it's really important that we're using a pain scale that has been validated for acute pain in the species that we're assessing. And that's in comparison to something that's been validated for chronic pain, which would be more appropriate choice if we're looking at assessing how well our analgesic protocol for an osteoarthritic patient, for example, and how well that's doing. So validity is the one thing that we need to check for, making sure we've got the right pain scale for the right job. And then the last thing is making sure that's user-friendly. So it has to be easy to use for everyone. If it's complex, it's unlikely that the clinic will, wholeheartedly adopt it into protocols. So let's make sure that it's user-friendly and that everyone's comfortable with using the pain score that has been chosen. The good news is that the amazing panel did put together a list of the pain scoring tools that they recommend for both acute and chronic pain. So a good example would be for the cats, we've got the feline grimace scale for acute pain there, and then we've got the Glasgow composite measure pain scale for acute pain in dogs. There are a whole host of other ones that have been listed as well, including some for chronic pain as well, even though it's a perioperative analgesic document. The panel felt it was important to also list some of the validated pain scoring tools for chronic pain as well.
Yeah, and that is very important, because a lot of patients in the acute perioperative period, or at least some of them, may go on to develop chronic pain, and it's really important to have those validated scales for that setting. Perhaps, in several weeks' time after an orthopedic surgery, an animal may be still feeling discomfort, and that's that's a maladaptive response to some sort of insult rather than an acute response, a physiological response to some trauma or injury. So the measurement tools definitely make a difference, don't they?
Yeah, absolutely.
So in the guidelines, there's a lot of information that's been presented on the different types of analgesia that we've got available to us as veterinarians, including opioids, non-steroidal anti-inflammatory drugs, alpha-2 agonists, local anesthetics, and ketamine, as well as combinations and various combinations of a whole lot of those agents that I've just mentioned. I want to specifically talk a little bit about perianesthetic non-steroidal anti-inflammatory drug administration, because this is always a topic that generates discussion, especially around that period of anesthesia and the potential, I guess, or risk of adverse events. And even, do we give them to some patients and not others? How do we select a patient we might give a perioperative non-steroidal anti-inflammatory drug to? So how do the guidelines present non-steroidals in the context of the presence of comorbidities or other risk factors, maybe the risk of sepsis, hypovolemia, and those kinds of things?
Yeah, absolutely. So I guess the way the guidelines really talk about non-steroidal anti-inflammatories is they do acknowledge that sort of controversial topic. And we sort of spoke about earlier that, conflicting recommendations in the literature, they really do sort of talk to that there is, a whole heap of information out there. What the guidelines really talk about is, first, they talk about the mode of action of non-steroidal anti-inflammatory drugs and the reasons why we could be concerned around using them in that perioperative period. And specifically, as you mentioned, what we are really concerned about is obviously blood flow to the kidneys. So the way that the guidelines set it out is they really talk about, the pathophysiology about why we are concerned about sometimes using them, but not to be so scared that we don't use them at all. And then they sort of answer that question that we all have is when do we give them if we do want to use them? Is it during the pre-medication? Is it, in recovery? When do we use it? And really the guidelines in a nutshell, I'll let the readers actually, read the further detail, but in a nutshell, the recommendation is absolutely we can still use these non-steroidal anti-inflammatories. But in terms of patient selection, they give us a list of which patients we might want to avoid them in. And as you mentioned, those patients with those comorbidities where we are really concerned about, renal health, if a patient is, for example, what's a good one, a high risk for hemorrhage, during anesthesia, that would be one that we would maybe avoid using non-steroidal anti-inflammatories in. But by and large, the message is let's not be scared of these products. We can still use them, but let's just be selective in how we choose them and understand it's all to do with mainly their blood pressure and blood flow to the kidneys. So if we have concerns with how a patient might handle that under general anesthesia, are we then potentially waiting until recovery once we're comfortable that the blood pressure has been over 70 millimeters of mercury, during recovery? So we know that blood flow and that blood pressure is good. And at that point, we can use the non-steroidal anti-inflammatory. So I think what I really like about that particular section is just the confidence that it would give clinicians with when to pick it, when to use it, when maybe to avoid it, and just the understanding behind what it is that we're concerned about. And it is mainly the kidneys, because we know that during anesthesia, we can get that sort of hypotension that sort of comes hand in hand with isoflurane. So just having that understanding and then confidence of when to pick it.
That's great. And I really like that because, we have this enormous array of analgesic drugs available to us, particularly in the part of the world where we live in Australia. We're not limited pretty much by anything in terms of what we can give to our patients. And it is about risk assessment for those patients and about making an informed decision about what's right for our patient. I mean, these are prescription animal remedies after all, so we do need to factor in comorbidities and other things. And yeah, I really like that approach. It seems like a sensible approach and a rational one, and the one that gets away from a dogma that every patient gets the same anesthetic protocol. As you alluded to before, there are some procedures which demand a different type of anesthetic analgesic protocol, and there are other procedures that demand something different again. So I think that really encourages that thinking process around what we're doing when we're giving medications to a particular animal with a particular disease.
Yeah, absolutely. And I think you've just really nailed a very important point to my heart, which is let's move away from those set protocols. Let's look at the patient in front of us and let's really just tailor the anesthetic protocol from, what pain relief we're going to use, what sedatives we're going to use, really tailoring that to the patient in front of us, as opposed to the one size fits all approach.
Absolutely. Now, the guidelines also present some really good information on the various analgesic techniques, such as local nerve blocks, continuous infusions, and the use of multimodal analgesic techniques as well. Tell us a little bit about what's covered in the guidelines with respect to some of those techniques.
Yeah, absolutely. So in my mind, we're sort of separated into basically the other techniques section. So we have a section that's on the local anesthesia side of things, and then another section which is termed, I think you could correct me if I'm wrong, but I'm pretty sure it's additional analgesic techniques. So I'll talk to each of those separately. Starting with the local anesthesia techniques, here they're really focusing on, I guess, promoting the benefits of using local anesthesia techniques during an anesthetic. And they're really just talking about the fact that local anesthesia really provides excellent targeted pain relief whilst reducing the general anesthesia that we are requiring for our patients. So that has benefits that are twofold. So not only is that beneficial to our patient, because we know that isoflurane is actually the biggest contributor to vasodilation, hypotension, and overall cardiovascular depression. So anything that we can do to reduce the vaporizer setting is great for our patient, but we also know that it's a huge benefit to the environment as well. So again, knowing that isoflurane acts as one of the largest contributors to the carbon footprint of anesthesia, again, anything we can do to reduce the setting on the vaporizer will also have a huge benefit to the environment as well. So they're really talking to, that benefit, that dual benefit of using local anesthesia to reduce isoflurane setting. And the section really sort of splits into talking about the different types of local anesthesia, local agents, that we have available to us in the market. So lidocaine, bupivacaine, ropivacaine. So it talks to, each of those different products, their indication, the doses that we want to use, any contraindications that might exist. And they also have some really key good pointers to avoiding toxicity when using local anesthesia. So again, a bit of confidence in that space, because I know when I was in clinics, that was something that I was acutely aware of and quite nervous about. So it sets it out really clearly there, which is I find super helpful. There is also specific information on how to perform, things like epidurals, which can be, again, quite daunting, but manageable. We can do these things in clinic. So it talks to, again, all the contraindications, the reasons why you would want to use epidurals, doses used, and then there is specific information, specific references that the panel recommend for further information on things like epidurals that can get a bit technical. So they'll have a list of references there that the readers can see. An example would be the Handbook of Small Animal Regional Anesthesia and Analgesia Techniques by Lurch. So that is another reference that sits there for the, epidurals and some of the more complex local anesthetic techniques. But as you mentioned, there was also another section that really talks to the additional analgesic techniques. And that section really gives readers information on the use of analgesic doses of ketamine. So we're not talking about ketamine in the anesthetic setting. We're really talking about it using ketamine as an analgesic in that, overall perioperative setting. And where they're really recommending the use is, as an adjunct. And it can be a really powerful tool to use when we're using it alongside other analgesics as well in that whole anesthetic protocol. So the section talks to when would you use a ketamine infusion, the sort of doses that we want to use, adjusting the doses based on whether your patient's gone into recovery or whatever it might be. So there's a nice little guide there for readers as well. And then it also talks to multiple infusions, so like your MLK infusions, which again talks to indications when you would want to use those sorts of infusions. For any listeners who are sort of thinking to themselves, what is an MLK infusion? That's when we combine methadone, lidocaine, ketamine. It can have some variations to that sort of recipe, but it's sort of a multi-analgesic infusion that we give to patients during anesthesia and in their recovery as well. So again, it talks to the different type of doses that you would want to use. Now, on that topic, the panel actually recommends using multiple syringe drivers to administer your analgesics separately. That's the gold standard in how to deliver these drugs. But they do also offer a recipe for a combined diluted infusion within a saline bag. And that might be a little bit more practical for clinics that do not have access to multiple syringe drivers. So just a nice addition there that gives us that practical sort of recipe. That's probably the best word to use, the recipe that we can use if that's, easier for clinics to do.
Great. Yeah, no, I think sometimes when we're running short of syringe drivers, I'll combine, say, fentanyl and ketamine in the one syringe, and then I'll have a separate one for lidocaine because, some of the patients who are anesthetizing, if it's a ruptured spleen or a GDV, they may develop ventricular arrhythmias, and I might want to adjust the dose of my lidocaine up a little bit, which I can't do if I've combined them all in the one syringe. So I certainly get why the separate syringes are really helpful because you can individually dose, and obviously ketamine is great for MAC reduction as well, isn't it? You can
Absolutely.
reduce the isoflurane concentration. So for those compromised patients, it's a really helpful thing to be able to give alongside. In fact, lidocaine will do exactly the same thing as well. If you're just using an opioid plus lidocaine, you'll get some benefit also.
Yeah, absolutely. And I think what I've noticed, I guess, just when I'm talking to clinics is just this question mark on how do I do this? How do I get the maths right? Like, this is just something that's really concerning me. And then rather than risking patient compromise, which I completely understand, the tendency is just not to do it at all because I don't want to harm my patients. So first, do no harm. So what I really like about these guidelines is you have these experts that are telling you this is the dose you would use, this is the rate that you would run it at, this is the rate that you would change it to when you're in recovery, all of those sorts of stuff, just to hopefully make it a little bit more accessible and hopefully, have a lot of max sparing for patients out there.
Absolutely. That's fantastic. It's been such a great conversation. I've thoroughly enjoyed talking with you today. I just want to finally ask, and maybe I should have opened with this, but where can people find these guidelines to download and what other information does Zoetis help to help veterinarians in their daily practice? Because I know there's a great website, the Think Anesthesia website, but there's a bunch of other resources that you have. So yeah, tell us more about where we can get this help.
Yeah, sure, absolutely. Yes, it would not be very helpful if I didn't tell you guys where to actually find the guidelines. So, first of all, if we're just talking about where we can find the guidelines, there's a couple of ways in which you can get your hands on them. So, if listeners are more into a hard copy that they can sort of have in the clinic and sort of pull out and have a look at, the easiest way to get your hands on a hard copy is actually just to reach out to your Zoetis representative and they will actually bring you a hard copy. So, they have them there for you. If you are more of a digital person and you want it now, the easiest way to do it is actually just to Google AVAP. So that's AVAAAP, and it will be the first search result. Will actually take you to the Zoetis Expert Lounge where you can download a digital copy. Okay, so that would be the easiest way. For any listeners who are not familiar with the Expert Lounge, and you mentioned we have a whole heap of resources, we've created sort of a one-stop shop for all of our clinical resources because we know that we have various different websites that have different resources here, there, and everywhere, and it can be quite difficult to find exactly what you're looking for. So we've created the Expert Lounge now, and that basically is not just limited to anesthesia. It has all of the Zoetis portfolios, including osteoarthritis, dermatology, but under the anesthesia portfolio, so when you enter that sort of lounge, under the anesthesia portfolio, you will find those guidelines as well. So there will be a link there. And there's also a link to, as you mentioned, Think Anesthesia. So Think Anesthesia is a anesthesia specific website that we do control and run, but it's not product focused. It's really just on anesthesia. We have a whole host of webinars on capnography, hypotension, you name it, it's there, and it's all run by specialists for us. So it's a really beautiful resource. Within Think Anesthesia, there's also sort of like downloadable resources for clinics, things like capnography charts if you need help sort of interpreting waveforms, emergency dose charts as well if you want to, print those off and have them in clinic. So that's all on the Think Anesthesia website, but you can access it through the Expert Lounge. And to access the Expert Lounge, if you're sort of thinking, okay, that's great, but how do I get there? Just Google the Expert Lounge and it will be your first search result that comes up, and then you'll have access to all of the Zoetis resources.
That's awesome. There's so much good information. I see there's resources for veterinary nurses and for veterinarians as well. There's webinars, podcasts, a whole range of other things that you've got as well. It's just such a tremendous effort that everyone has put in to make these things available. So huge thank you from me who works in emergency practice, these things are just such a godsend for us, in fact, in making our lives a lot easier. And even though I've got grey hair and I'm getting old, and I think I maybe should know more than sometimes that I do, these things, this information is just so nice because we brought together so many disparate and far-flung resources into one really convenient place for people to find. So thank you so much for doing all of that work and for your passionate drive behind the guidelines and behind this anesthesia project. Dr. Steiner, it's been absolutely fantastic speaking with you today, and we hope that you found this podcast really, really helpful. But thank you again, Dr. Laurie Steiner.
Thanks, Phil. Thanks for having me.
You're welcome. Thank you for listening to this episode of Vet Synapse. If you like this episode, please subscribe to the podcast and share it with your friends and colleagues. Make sure to visit our website at veteducation.com.au for more great content and to experience the latest online race-approved veterinary continuing education.